Right, good afternoon. Welcome everyone. Thank you all for joining us. We have excellent speakers for you today. Today's talk is entitled The Impacts of COVID-19 on Child Health Services. First, we have Dr. Blaisdell, who is a pediatrician, a researcher, and an advocate. She's an assistant professor at the Tufts University School of Medicine, and her clinical practice is at Maine Medical Center Pediatric Clinic. She has also served as the medical director at Camp Winnebago for 20 years. Dr. Blaisdell is currently the vice president of the Maine chapter of the American Academy of Pediatrics and is a founding member of Maine Families for Vaccines. Additionally, she has served as the site director for the National Children's Study, as chair of the Institutional Review Board at MMC, as chief of pediatrics at Intermed, and is currently a trustee at the Mercy Hospital in Portland. Our second speaker, Dr. Wendy Davis, who is a professor of pediatrics and a founding member of the Vermont Child Health Improvement Program, or VCHIP, at the UVM Larner College of Medicine. She is also the associate director for the National Improvement Partnership Network. Dr. Davis has experience in the clinical practice of pediatrics, in medical education, and in public health executive leadership, having served as Vermont's Director of Maternal Child Health and as the Commissioner of Health. During Dr. Davis's tenure as commissioner, Vermont achieved one of the highest rates of influenza vaccine in the US for the school-age population by establishing statewide school-located vaccination clinics. In her current role, she oversees a statewide network of 51 Vermont pediatric and family medicine practices that engage in projects to improve healthcare delivery and outcomes for Vermont's children, youth, and families using practice-based quality improvement tools and methods. Her actions at the onset and throughout the duration of the COVID-19 pandemic have laid a firm foundation for future quality improvement work to reduce missed opportunities and increase for vaccination in Vermont, with a focus on our rural communities. Thank you so much to both speakers for joining us today, and we'll get started. Blaisdell.
Thank you so much, Jessica, for that very warm introduction. It's nice to meet you all. I am as Jessica billed, the incoming president of the Maine AAP, among other things, and I'm sharing on behalf of many people in Maine, certainly not just my own work, but I think I was the elected spokeswoman for today's conference. So nice to be with you. I'm going to share some of the activities around improvement and communication that the COVID-19 pandemic allowed us to put into place. First of all, to talk a little bit about communication. Certainly, we all know that communication became a very important aspect of coordinating our responses to the COVID-19 pandemic. Very quickly, our state chief child health officer, Dr. Amy Belisle, started weekly women and children's calls on Fridays and at noon, and that was a partnership with the Maine CDC, the DOE, all of the hospital networks in Maine, Maine AAP, and our maternity providers. It allowed a weekly collaborative call for us to all come together and brainstorm, get collective up-to-date information, and troubleshoot issues that we were seeing throughout the healthcare delivery system for children in Maine. We also started having ongoing calls about vaccines and therapeutics as the pandemic shifted into these areas. Those calls are now monthly as opposed to the initial weekly calls that we needed to begin with. We did the DHHS in the state of Maine, probably much like a lot of states, had their websites revamped and updated for kind of a one-stop shop. This is Maine's government site where we can get tested, get vaccinated, get treatment, learn about the COVID levels, and then kind of more about supporting families in terms of where to get childcare, how to get general assistance, or otherwise find help. So that was something that was a very important aspect of providing services to families in Maine. As the November 2020 season came around and pool testing became available, DHHS supported the rapid antigen testing at schools, the pool testing at schools, and continues to provide support. And then in May 2021, excuse me, they started the pool testing, and we currently have over 500 schools who are participating in that pool testing. Maine also encouraged families and made COVID-19 tests available to families, and over 125,000 tests were available to Maine residents through the Project ACT website. As of this month, Maine CDC has updated their quarantine and isolation guidance, like many of us did, with the additional test to stay option but not only for schools, but for childcare. And so we've been distributing those home tests to childcare programs, which is increasingly important as that population of children are waiting for vaccination. A lot of collaboration with DOE in Maine. The DOE created a public health response team, and that became a central point of contact for schools, since there were so many aspects of the pandemic coordination that were affected and employed in schools. That team included a coordinator, 3 public health specialists, 9 public health liaisons, and a contact tracing team that helped schools through the 2021 and through the winter of 2022. In addition, we created a school health advisory group that was school nurses and physicians, and they were meeting weekly through the first wave of COVID, and then we've been meeting monthly to help address the needs and highlight some opportunities for collaboration between schools and physicians. And I'll highlight a couple of the outcomes of those collaborations in a few slides. Focusing on vaccination, I think one of the first things that Maine did was be very transparent. I know Wendy, Vermont is somebody who we always aspire to in achieving your immunization rates in terms of COVID. But we in Maine were able to publish our immunization rates by age, zip code, and school administrative unit, so that we had transparency on those numbers. We addressed access. As many of us know, those initial large vaccine expos and drives that were available for adults were not available for children. So the ability to provide the vaccine in the medical home became very important. So the Maine immunization program currently has 177 providers with 5 to 11-year-old vaccine inventory, as well as the 12 and ups. And early in the pandemic, access to vaccines in general had decreased, and many of our providers collaborated on curbside clinics, and not even worrying about getting out of the car. We'll vaccinate you as you come through the drive-through. So that was a unique way to address that need. Of course, like many of us, we in Maine had vaccine clinics at school. We had over 100 school clinics from May to June, and 420 school and community clinics in that second wave with the 5 to 11s from November to January. We continue to have pop-up vaccine clinics with ongoing events with our public health nursing and pharmacies throughout Portland and Lewiston as the requests are being made. Currently working on using the summer camp setting as another opportunity to do vaccination. And both the Maine Immunization Program and DOE continue to update their school located vaccine guidance to include the COVID-19 vaccine. The promotion of the vaccine and the support of COVID-19 vaccination was undertaken by a campaign, the Brave Like Me campaign that the Maine DHH put on. That website created a Brave Like Me website for information. There were Maine Care information sheets that were translated into several languages. And then we created the 5 Reasons to Vaccinate brochure. And for fun, we, Maine DHHS and DOE held a contest, a video contest for kids to participate in. And I'm going to just take 30 seconds and do some multimedia here to share the winner of that contest.
COVID stinks. People are catching it and getting really sick. We use lots of stuff to keep us safe, like seatbelts, or sunscreen, or a life jacket. In case you fall in. Same with the COVID-19 vaccine. It's just a quick shot, and it'll protect you and your friends from COVID, so you can play with your friends again. Think of your COVID-19 vaccine like your superpower.
So always great to see some of our future leaders, their humor and encouraging us to be vaccinated. So wonderful to see. Additionally, we created Maine Vaccine Partners. This was a collaboration of many individuals. This was a Maine AAP collaboration to do education and communication, to bring about forums, to do radio campaigns on vaccine communication, and provide a website, a one-stop shop that was outside the government site for families. We find in Maine, our rural populations can be very hard to reach, and have found that radio campaigns have been an important part of reaching our populations. So many of us spend a lot of time driving in our car as we're coming in from out of state and outer parts of the region. And so I just wanted to share with you again a voice that of children that we created a radio campaign around.
Hi, I'm Lexi, a 10th grader in Maine. Due to the recent COVID-19 spikes, we haven't been able to be in school as much. Getting vaccinated means kids are less likely to get sick and spread the virus. And if you are vaccinated and become a close contact of someone who is sick, you don't have to quarantine if you test negative. So if you like working in front of a computer screen all day, that's all right. But if you're like me and don't like sitting at home, the COVID-19 vaccine might be for you. For more information, talk to your healthcare provider.
A message from the American Academy of Pediatrics Maine chapter.
Hi, I'm Lexi, a 10th.
Sorry. So again, using youth voices to really promote that vaccine is clearly a campaign tactic that we used in Maine. This is the Maine Vaccine Partners website, just a one-stop shop for families and other folks. And one of the things I found was that we did include was, a directory, so that people could really just very quickly email the individual that they were needing information from. I had mentioned before that there were those collaborative opportunities between DHHS and DOE and Maine AAP and our schools. And I just wanted to share some of the guidelines that we created that we felt were very helpful to providers and schools alike. First, assessing children with symptoms, a very common problem as schools were trying to come back into play. Our infectious disease folks, this is very busy, not to follow every arrow, but our infectious disease team at Maine Medical Center worked with AAP to create a flow sheet algorithm for school nurses and for providers for the best practices. This was, way back from October, but best practices for how the guidelines were recommending evaluating kids with symptoms. We had a similar sheet for those who were exposed. We, like many of those states that were using pool testing, had pool testing algorithms that were easily accessible to our school nurses. We had, when the initial quarantine guidelines came out with that full vaccination, they were a little bit difficult for people to interpret. So we created, the Maine CDC created this sort of flow chart that was a very simple, easy flow chart of what to do if you test positive. There was one for quarantining as well. And of course, as kids started contracting COVID and then needing to return to play. The CDC and Maine AAP worked with our sports medicine teams to create algorithms for how to return to play if people had different symptoms based on their symptom severity. And this is the latest iteration, which can be found on the Maine AAP website. All of these toolkits can be found there. And then, the communication piece back to the school became very important. So this was our return to play progression on one side for sports. And then the other side is the permission form from the provider to the school. And then my last slide before I hand it back to you, Jessica, to talk to Dr. Davis, hear from Dr. Davis, was a personal passion of mine is summer camp. I've worked as a medical director in a summer camp for many, many years. And so Maine was able to work with state and federal partners to provide best practice guidelines. We did have camps that were open, as did many of the New England states in 2021 and 2022. And we were able to do evaluations of the best practice, public health practice in those settings and share them. So Maine is continued to be such a great partner with our summer camps and making sure that those experiences are available to children. So I will stop sharing and hand it back to you, Jessica, or maybe directly to you, Wendy.
Hi, everybody. Let me try to share my screen. Hang on just a moment here. See if we can get this going. All right, how is that looking? Are we good?
Looks good.
All right, thanks. So hi again, everybody. Thank you also, Jessica, for that lovely introduction. Thanks, Laura. And Laura's talk, I will say we coordinated pretty informally on our talk, but you will quickly see there are some very similar themes in what I'm going to talk about. And a couple of thoughts I had while Laura was speaking were just something that I think about often, which is how fortunate we are to have our collaboration across Northern New England, particularly in times like this. And Maine in particular and our AAP chapters have been great partners. And it also made me think about the mantra that really in some ways all public health and pandemic response is local. We love our federal partners, but as you could see, I think in some of Laura's work, that a lot of what happened over the last couple of years has really required some local adaptation. So you'll see some similarities, but I'm going to go ahead and let's see. There we go. So I do have just a few learning objectives for you. And I'm going to probably concentrate a little bit more on the infrastructure part of what happened here in Vermont. So I really want to present as a theme how the integration of our response by public health and child health professionals, including my group, the Vermont Child Health Improvement Program, and then our community partners, was really a foundation for supporting our approach to the pediatric pandemic response. So as I said, I'm going to tell you a little bit about our structure, some of the content that we developed and shared and themes, and then the work products that have emerged from this. And I'll end with just a note of thinking together about what's ahead. I did want to quickly, though, acknowledge this is an effort that has really taken a village, if not a state. I think it has been a state. These are just some of the folks that I work with at VCHIP and our partners at the University of Vermont, Larner College of Medicine, and in the Department of Pediatrics there. And I'll say more about some of these folks. But I do note also that my partner in crime on what I'm about to present, Dr. Brina Holmes, is on with us today. And I am just incredibly grateful to Brina for that partnership. And then a ton of other partners. In particular, you're seeing here folks from the Vermont Department of Health Maternal and Child Health Division who have been with us all along this journey. And we partnered, as Laura did in Maine, very closely with our State School Nurses Association and in particular their leadership group. So here is some more about our integration and partnership framework. And we have actually at VCHIP had a very long standing, a couple of decades now, a central theme of integrating with folks at the Department of Health, but also our professional organizations like the Vermont chapters of the AAP and the American Academy of Family physicians. We actually enjoy some annual grant funding from the health department to support what we develop together as annual mutual goals for improved child and family health care delivery and outcomes at the population health level. And over time, these partnerships have expanded to include many, many disciplines across our communities that serve children and families. And we actually have what we call our public health primary care integration work group. We meet monthly, and this was really set up as a forum to address rapidly emerging issues. And so when this pandemic came along, this was the perfect infrastructure to support our work. And I'll just point out in the photo on the lower right, you'll see a tall gentleman in the back. That is now our health commissioner, Dr. Mark Levine. And Mark got interested in the integration work that we were doing even before he became commissioner. And so having that relationship, again, was really central to our success in some of the work that we did. As Jessica mentioned, I was actually serving as health commissioner during the H1N1 pandemic. And so back then, I learned a lot by going back to national documents about how you prepare for a pandemic. And I'm not going to spend a lot of time on this slide, but you'll see that all of these bullets, which go back to a report from the National Governors Association in 2006, these are all issues that obviously came right to the fore when we started into the COVID-19 work. And so the depth and the intensity of this pandemic, what would be impacted in terms of our medical response capability, and the need for the kind of partnerships that I just described in order to have a successful pandemic response. And I learned a lot by serving as commissioner during that last pandemic. I learned about, again, sort of that disconnect that can occur between federal guidance that's coming out and what's needed at the local level. Really just the variability across different healthcare settings in terms of what folks were prepared to do. And then, of course, the response by our population and what their needs were, and just the impact, and of course, much, much greater, just exponentially greater in this pandemic than H1N1, but the impact on our healthcare staff and resources and our safety net resources as well. And so just a quick run to take you back a couple of years ago. In March of 2020, the Vermont Department of Health issued their first health alert, noting that at that point in time, it seemed like there was little risk from COVID-19, except for certain groups who might have been exposed or been in locations where there were higher levels of illness. But in late January, early February, our health department actually activated their Health Operations Center, which is a branch of the State Emergency Operations Center, to prepare for what might lie ahead. And March 7th of 2020 was when Vermont identified our first case. And shortly thereafter, our leaders in the Maternal and Child Health Division at the Health Department became an active part of that Health Operations Center, very quickly moved to discussing whether or not school closure was needed and how those decisions would be made. And then our state epidemiologist and Brina, my colleague, who was then serving as the Maternal and Child Health Director at VDH, got together and added teams who could specifically address issues like children's health issues and issues in school and child care. And our child care oversight resides with our Department for Children and Families. So they became part of the HOC as well. And then the entire State Emergency Operations Center was activated. Our medical staff at the University of Vermont Children's Hospital very quickly, as they did in Maine, became engaged in discussion about procedures and policies. And really a central point for what I'm about to describe happened on March 13th, when we at VCHIP met with the leadership of the Maternal and Child Health Division and said to them, this was again a longstanding partnership, we know right now folks are focused on adults. We want to be focused on child and family health. How can we help you at the health department have a successful response? And then that same day, literally, our Governor Phil Scott issued his executive order and declared the state of emergency. And that Sunday, he ordered the closure of public schools by the following Wednesday, so a few short days later, which of course created quite a maelstrom. And so that week, as they did in Maine, we began to set up a series of calls that would be focused with our statewide partners in healthcare, but also the education and child care communities, community agencies that serve children and families, focusing on the pediatric aspects of pandemic response. And these slides are very dense. Again, I'm just going to highlight a few bullets, but they will be available if you're interested in the details. And the reason we had an infrastructure in place to do this was at VCHIP, we had established several years ago a statewide network of practices that engage with us in child health quality improvement, practice-based improvement. We call our network CHAMP, named after what used to be our, well, still is, I guess, our mascot for our minor league baseball team, and also the Lake Champlain Monster, who is named CHAMP. But we started, as they did in Maine at the beginning of the pandemic, setting up this series of calls by leveraging the partnerships that were in place. We decided we would really focus on the child and family health aspects of this. We would provide situation updates, follow the epidemiologic data, certainly follow and present the public health and clinical guidance, and then practice adaptations and innovations which would be needed to continue delivering care. Initially, we were using an Adobe Connect platform. We moved not that long ago, actually, to Zoom as folks became more and more familiar with Zoom. And along with Brina and I led the calls. She was, again, then the MCH director at the health department, but she has subsequently joined us full-time at VCHIP, for which we're very grateful. And our calls were initially 4 days a week. It just seemed like the tsunami of information warranted that frequency. But by June, we were able to scale back a little bit. And then about a year later, we scaled back to just once a week, which is our current frequency. We continue to have calls once a week, and we're looking ahead and probably going to scale back even more in the months ahead. We really wanted to just support our network members initially, but then leverage those partnerships to bring in a lot of community partners, as I mentioned. And so we started with those 50-ish practices in our network, but very quickly pulled in childcare, education communities, all sorts of child and family serving agencies in our communities. And we tried to use our own internal continuous quality improvement to get feedback and tailor the calls to what people were needing. Every night after the call, we send an email to the call group with all of the links and the information from the day and the slide set from the day. We have a slide presentation every time we do a call. And then we have a website that is really dedicated now to hosting all of the resources that we had shared over time. In addition to myself and Brina, we invited often expert presenters to come in and talk about specific issues, and they came from different quarters: primary care docs, our specialists, health department partners, and even the insurers and payers. One Care Vermont is our single statewide ACO, and also the professional organizations to help us present content. And as of this past Wednesday, we have conducted 232 calls, and I don't know where the last 2 years have gone, but that's our volume to date. And as I said, these are the links at which you can find the materials that we've archived. This is our call participant summary, and I do need to update some of these statistics, but again, since inception, we've had close to 20,000 participants. That's the total if you add up the number of people who attend each call each time. It's an unduplicated number, but it's the calls, it's over that series of 232 calls. And at one time, I think this was about a year ago, I had calculated we had about 680 unique participants, but I need to update those stats. But really, what I want to show you is this map and show you that we were able to garner statewide coverage, which was really terrific. And not only public health partners, but again, folks from our hospitals and specialty care providers, a lot of school partners, and then of course primary care practices, and some folks representing medical education. And I recently just pulled some of the webpage analytics from the calendar year 2021. This was fun to see because I really hadn't been paying attention, but it turns out we were the #1 for our VCHIP website, the #1 in the top 10 visited pages for calendar year 2021. The visits were 10,000 out of about 44,000 total. So fun to see how that evolved over time. And back again, about a year ago, our commissioner from the Vermont Department of Financial Regulation had done a look back for a presentation at what the topics covered were in our governor's weekly, actually initially they were several times a week, and then weekly press conferences. And I'm not going to spend time on this, but these topics I think won't surprise you. They kind of followed the curve, if you will, of what was happening with the pandemic. And so we have pulled what our call themes were from this health department VCHIP partnership. And in 2020, again, you can follow the calendar and see that over time, the call content really followed what was happening in the pandemic. So early on, We were very focused on primary care delivery adaptations, including trying to help our practices quickly ramp up to deliver care via telehealth. They wanted to be paid for what they were doing, needed to be paid to keep the lights on, and so we worked on some advocacy there. We began very quickly to see the psychosocial impact on our children and families and tried to begin to address that as early as possible. Very quickly, Vermont's child care centers that had been closed reopened, so we were supporting those providers and how to safely care for their children. And then we began to talk, through the summer about reopening schools which had been closed in a much more robust and in-person way for the fall of 2020. And it's interesting, if you look back, it wasn't really until August that the National American Academy of Pediatrics began to put out, in association with the Children's Hospital Association, some very robust pediatric data about how COVID-19 was impacting the pediatric population. So we began to follow that as well. And similar to Maine, we did a lot with our school partners for school reopening and also thinking about return to physical activity and sports, particularly if children and youth had had COVID-19. We created algorithms as well, one for kids returning to school, but also the adults in our partnerships wanted an algorithm for teachers and school staff. And then, of course, we hit the vaccine train and began to follow that in terms of COVID content. And throughout 2021, again, I won't spend a lot of time on this, but new issues emerged like MISC, the cardiac risks that could possibly be associated or needed to be screened for, I should say, in terms of return to activity and physical education. Mental health was becoming all-consuming in terms of an issue that folks needed help with. And then ongoing evolution of guidance related to masking, related to new variants that emerged, and a heavy emphasis on school guidance in the fall of 2021, and then new vaccine developments. And I note that the focus in the CTR on health equity, and that really was a topic that was of special interest to our constituents as well. And we were able to present content that emerged in parallel with some work that the Vermont chapter of the American Academy of Pediatrics was doing. Our president, Dr. Rebecca Bell, who is a pediatric intensivist at our Children's Hospital, set up a task force on race and health equity. And that really, became sort of a theme that was paralleling what we were delivering in terms of COVID-19 content. Just as one example, we were delighted to welcome Vermont's Director of Racial Equity, Susanna Davis, who presented about the work that she was doing at the time. We were also following the impact, both in Vermont and nationally, the negative impact on preventive health service delivery. And so we were following what was happening to well child visits and even things like blood lead screening, procedures that essentially needed in-person care, but in a time when much care was being delivered virtually. And we were worried about things like oral health care as well. We had many days that we just called potpourri because, again, lots of information coming forth and just trying to keep up with what was coming out and sort of present the highlights of the day or the week. And then we were following national and international developments as well, both in terms of the epidemiology, vaccine information, variants, but just, trying to present that as a backdrop. The National American Academy of Pediatrics also ramped up very quickly with sort of a health operations center type approach to their information and guidance. And again, similar to what we were seeing coming out of the Centers for Disease Control and Prevention and folks like the FDA and the White House team, the AAP nationally really had a very rapid and robust response, but often we found that we would need to take their guidance and then look at what was happening in Vermont and adapt it locally. So we were able to do that as well. And I'll just end with a few slides on what we feel, and I think, Laura, you reflected this as well, was one of our greatest success stories from the beginning. And again, I credit my colleague, Brina Holmes, who had actually served as the chair of the National Council on School Health for the American Academy of Pediatrics. So passionate about school health. And Brina was able to guide us in really focusing on reopening in-person schooling as early as possible, but creating a climate in which parents and caregivers and teachers and staff and students could feel safe in re-entering the school environment. So as we did with everything, we followed the data, the science, we looked to our expert opinion. Like Maine, we had a multidisciplinary task force. we developed what was called the Safe and Healthy Schools guidance in very close partnership with school nurses and the Vermont Agency of Education. And we did a lot of community outreach and engagement, again, as they did in Maine, with pediatricians and other local experts presenting evening webinars to an audience of school personnel, parents, and caregivers all over the state. And those were very well received. And then lots and lots of advocacy. And you see again in this photo, that's Dr. Becca Bell, our AAP Vermont chapter president, who made a number of trips to the podium at the invitation of the governor at his weekly press conferences to really be that trusted voice of a child health professional, emphasizing the guidance and encouraging parents and caregivers to meet with their child health professionals if they had questions and concerns. And this was really just the context for that school work. And of course, what we found was that we were able to safely reopen schools. Fortunately, the impact of COVID-19 on the pediatric population in terms of illness burden was less, but not absent. And so we really paid close attention to mitigation strategies that would help keep our children safe. And so I will close by saying that we really had this decades-long history of public health and healthcare integration that I think was the platform and the foundation for our success in pediatric COVID response. As I alluded to, and as you no doubt recall, very early in the pandemic, there was so little attention paid to the child population. And to some extent that was understandable, but at the same time, our community really rallied around wanting to be sure we were paying attention to what was happening with that group and adapting guidance as needed, and also supporting our pediatricians. So we really created the table, I will say, and this intersection of science, common sense, and public policy, which was translated into the content that we delivered in our calls. And as I said earlier, we were grateful for the national guidance and advocacy, but we found that we sort of constantly had to adapt locally. So the road ahead, there's still a little bit of uncertainty. I mean, it's certainly looking brighter, but I'm sharing a photo of mud season in Vermont because we aren't done with that yet, and I doubt that Maine is either. But we're certainly encouraged by recent trend improvement, but we have to continue following particularly the pediatric vaccine story, certainly following as new variants may emerge and what the impact of those might be. And we're still, like I suspect you are in Maine and New Hampshire, we face vaccine hesitancy and questioning among parents, and we welcome the questions and just really do our best to respond to those. But we have some catching up to do, both in terms of preventive care, but certainly in terms of vaccines, routine vaccines as well. And then addressing the mental, social, and emotional health of our patients, our families, our communities, and our colleagues. And we in Vermont, in particular, in the pediatric arena, saw a pretty significant impact on our pediatric trainees. And so we've really worked, and I credit the leaders of our College of Medicine and the Department of Pediatrics, Lewis First, and our residency program leaders with trying to attend to that. But we are committed to continuing this partnership and continuous improvement in our own process. And so we'll keep at it. And I'll end with this slide. I did just want to mention, and again, because Laura, you told some great stories. And when I think about well child catch-up, I'm remembering the days in late spring, I guess it was probably, of 2020, when we still had freezing temperatures, and pediatricians and family docs around the state were committed to continuing to deliver high quality well child care. And the stories of pediatricians going out into the parking lot, bringing their scale, throwing it in, having the parent open the trunk, throw the scale in the trunk, grab the baby out of the back seat, the 1-month-old out of the car seat, weigh the baby, put her back in the car seat, and then have the conversation. And I just am profoundly grateful to the creativity and innovation of our partners across the spectrum for being able to continue care delivery. So thanks for listening, everybody. I look forward to your questions.
Thank you both so much. Those were really informative talks, and I found myself reliving some of the anxiousness of 2020. We have time for questions for both of our speakers. Please feel free to either raise your hand or put them in the chat box. And I don't see any in the chat just yet, so I will start off as we wait for others. I wonder, it seems like there was quite a lot of infrastructure put into place in response to the COVID-19 pandemic. And I wonder if you have thoughts on what aspects of that infrastructure that was implemented in response to that crisis will be maintained or useful moving forward as we look at other healthcare challenges for our pediatric population.
Wendy, I'll start and then pass to you. So I think for many years, we pediatricians have been looking at how we can use telehealth as part of our care process, right? So so much of what we do when we're on call has been telehealth historically, counseling parents through the night, seeing when we can see them in the morning, doing that sort of triage. And I think additionally practicing in rural areas gives additional opportunity for telehealth to have come forward. Unfortunately, the infrastructure, the funding, the payment mechanisms, Wendy, we've talked about that. The payment mechanisms for the entire infrastructure for telehealth hadn't gotten catalyzed. And one of the silver linings that I really feel did happen during the pandemic for pediatric care and for mental health care was this final, creation of a telehealth system, right? That a telehealth system that we could use regularly in the moment. If somebody couldn't come in because they tested positive, well, why don't we just follow up via quick telehealth visit? Clearly, we'll do some pieces when you're out of your isolation, and also to be able to provide those mental health services. I think that going forward, we're going to find a lot more use of telehealth in mental health in rural places like Maine, when we're learning about the sort of cognitive behavioral therapies that can be quite effective, even from a distanced area. So I believe that telehealth was coming, but the pandemic gave us the opportunity to really put that into place and to figure out the payment systems. We still need to do work in terms of determining how to appropriately triage people through telehealth and those some other sort of ironing out issues, but a real benefit, I think, to patients and families is telehealth.
Thanks, Laura. I completely agree with the areas that you described. And I will just add one thing on the mental health front. We in Vermont, we've had a number of really terrific initiatives designed to increase access to and improve the quality of mental and behavioral health care delivery. And yet, at times, they have been somewhat disconnected, not well coordinated, and responsive to sort of whatever the crisis of the day or the year is. And, even pre-pandemic, we were seeing, as an example, children and youth ending up in the emergency room and spending long wait times in the emergency department because of the lack of inpatient facilities or even outpatient, partial hospitalization, intensive outpatient care. And so that was a theme even pre-pandemic. And of course, the pandemic has only exacerbated the prevalence, the volume of children that we're seeing and youth that we're seeing with those conditions, and exacerbated the strain on facilities. And so I think one of the opportunities here in Vermont took advantage of it this past year. There is a national funding initiative from the Maternal and Child Health Bureau and HRSA to fund what are called pediatrics or child psychiatry access programs. And many states had these pre-pandemic. Vermont had some similar initiatives, but they weren't funded under that umbrella. And so we applied last year, recognizing, again, this was really going to be a central theme of the recovery phase, and we were successful. These are pretty much now categorically funded programs, and we're just launching. But I think what will come out of this, with the help of funding like that, and hopefully future funding from the state, is a more solid and hopefully eventually very solid mental health care delivery infrastructure that will be accessible not only to the children, youth, and families, but also to all sorts of healthcare and public health professionals around the state who have been trying to knit together these resources. So I think that's a big one. And then I'll shift a little bit maybe to say a bit about public health infrastructure. We always have the potential to quickly become active with the Health Operations Center, the State Emergency Operations Center. I mean, the thing that I learned really in serving as Vermont's health commissioner was about this incredible infrastructure that is at the ready when we need it and can mobilize very quickly to respond to these sorts of emergencies. But as you know from the national news of the past few years, when we're not in the crisis, the funding diminishes, it gets diverted elsewhere. Our public health infrastructure really was quite decimated just prior to the pandemic. And so we had to very quickly, find new sources of funding, and thank goodness, that happened pretty quickly. But I fear that when the immediate crisis diminishes, that once again, we will head into a cycle where funding will be cut, infrastructure will be decreased. And so I think we really need to keep our eye on that and keep advocating as a health and research community. And the research is a huge component of it as well. When I was thinking about preparing for this talk, I thought, wow, there's no better topic to expose the need for this type of translational collaboration than this pandemic. And we need funding and support on all fronts so that we can develop vaccines and therapeutics, but so that we can also deliver care in communities. So I think that's really something. The infrastructure is potentially there, but we need to keep our eye on sustaining the funding and, if anything, building it out more and strengthening it.
Hi, Gary, go right ahead.
Well, there was tremendous amount of progress that was made in terms of advocacy for awareness of the importance of child health care, particularly in prevention, prior to the pandemic. What are some of the strategies that are being planned, that are being implemented as we try to restore that momentum post-COVID, both in Vermont, New Hampshire, and in Maine?
Thanks, Gary. I might actually on that one start a little bit on the national front, but I think those efforts do translate to very much to both Maine and Vermont. It's interesting, we have so many similarities in how care is delivered to our child population. The National American Academy of Pediatrics really is at the forefront of federal and national advocacy on a couple of fronts that I think are key, and always thinking about optimizing vaccine delivery and responding to vaccine hesitancy. So in fact, in 2022, addressing and responding to vaccine hesitancy is one of the National Academy's core priorities. A second priority is mental health care delivery, as we've just been talking about. And so when we have an organization as powerful, almost 68,000 pediatricians across the country, and the family physicians are just as engaged. When we have an organization that powerful, which has really leveraged the pandemic to get closer and be at the federal and national tables on this. So with the White House team, with the FDA, with the CDC, I think those relationships will be key in allowing the AAP to continue to successfully advocate and assure funding to support these child health priorities. And so mental health is a second national priority for the AAP, and we will be able to take advantage of products coming out there. And then I guess just, as those translate to Vermont and Maine and New Hampshire, I think, again, following the data. So we know the rates of, child care, vaccine delivery, other preventive service delivery, in some cases plummeted during the pandemic, while some of these conditions, the mental and behavioral health conditions, skyrocketed. So I think looking at those areas and, as we said, paying particular attention to the infrastructure to respond to those areas is going to be key.
Wendy, do you mind if I riff on that just a little bit? Because the other preventative health service for children is schools. And we think of preventative health as, our routine wellness visits, but I think the pandemic has laid bare how important schools, whether they be early childhood education or consistent attendance in in-person schools, how important that is to children's health and well-being, not only from free lunch programs or from the services that children get in school, or the ability to kind of keep track of children. So many children are still trying to find after the pandemic. They've just kind of been lost. So the AAP early on did a lot of advocacy in that summer of 2020 to talk about how important it was for schools to reopen, to figure out a way that it was it was part of our mantra as child health care providers to get schools open. And so I think one of the things that I realize now, and Wendy also commenting on public health systems disappearing when there's not a crisis, schools need to continue to be funded at the level that we have been funding them, and probably even more so, to continue to be those good places of preventative health care for children. I think we saw so many children's mental health get better when they started going back to in-person school.
And I wonder, kind of building on what you've both been talking about, I wasn't really aware of the degree of connection between the state and the work that was being done at VCHIP here in Vermont with the schools and the school nurses. And I wonder how much of that was in place before versus having been built up in response to the pandemic, and how do you see that relationship moving forward as we transition not only to talking about other sort of COVID-related health issues, but other health issues that are major public health problems for children, like the mental health crisis?
So, Jess, I would say in Vermont, there were strong partnerships in place. And again, I credit that to a couple of things. I mean, one is this just overriding framework of public health and healthcare delivery integration that we have had in place for some time. And so the partnerships with folks across the different divisions of the Vermont Department of Health, but in particular in the Maternal and Child Health Division, there is a very strong school health unit. In fact, they have a position that is the state school nurse consultant. They have some public health nurses centrally who work on that. And then in each of Vermont's health department district offices around the state, there is someone called a school liaison, often a public health nurse or someone with similar training, whose job it is really to connect with everyone in that region, that community or county that has to do with children and youth in schools. And so they connect with the schools, they connect with the medical homes. They're often a bridge between those entities. And they provide, again, they're the public health wind at the back, if you will, of the folks who are in those settings. So the partnerships were strong, and we've enjoyed tremendous leadership in our Vermont State School Nurse Association. But when I think back, even myself, I'm amazed and just grateful for how much stronger those relationships are now. I mean, the school nurses really were pulled in very early to our calls, but also those leadership groups that I mentioned that were developing the guidance. And we did not, as a pediatric community, we did not put out guidance without all of those partners at the table, not only from the public health department, but from the Agency of Education, the representatives there. Those relationships really gelled. And we're looking for ways right now. I mean, we have ways in place. Those are going to continue, and I think we don't see stepping back from those anytime soon. And Laura, I'm so glad you called out that importance of schools, because it's critical. And I agree. We don't have a lot of school-based health centers in Vermont, which many states do, and yet the partnerships are just as important. Our approach is, we may not have the health center right in the school, but let's connect the school and the medical home in whatever ways we can.
And I would say, similar to Wendy, we had the partnerships before. They're much more codified the communication streams and decision-making mechanisms and collaboration is much more secure. And I'm looking forward. Maine has received funding to expand 14 to 16 school-based clinics. And so we're looking forward to using those collaborations to continue to grow the medical home into the workplace of children.
Thank you both so much. Are there any other questions as we wrap up the hour?
Jess, can I mention one last thing? Because I realized I didn't specifically say this, but you know, the other, in pediatrics, we talk about the third space. So there's the children and youth, and Laura, you just reminded me of this. They spend time at home, they spend time in the schools, but then they spend time after school or in the evening or on weekends. And that became critical during the pandemic as well. And it's something we should call out because those partnerships also got strengthened, and we saw the importance of bringing those folks into this, you know, community of thinking about how we were both serving children during the pandemic and how we were going to help them recover after. So sorry for that late thought, but it was a really important and still is partnership.
This is Gary. I also wanted to go ahead and just end by saying that what you presented, both of you, is very, very informative, but more important, the roles that you played in leadership to be able to make things happen during these very difficult periods has been very much recognized and appreciated.
Thank you, Gary.
There we go. Thank you both so much for your time. I see lots of thanks in the chat box, but no additional questions. So with that, we'll wrap up. And thank you again. Nice to see you both.
Thank you so much. Good to see you, Wendy and Gary.